Okay, so let's look at a concept map for our patient. We have some initial data there, some labs, a little synopsis of what's going on, and medical history. This will all help build our concept map or care plan if that's what you do. But we can take that data and really, even the night before, once you've got your assignment and you know that they have renal problems, you can start to build it. So the next day when you come in, you really have it started and looking great for that nursing instructor. So we have an 86-year-old patient admitted following the flu. Doesn't say how many days, but they have nausea and vomiting, and they've had little PO intake. They're admitting data. They have low blood pressure, right, because they're dehydrated. The heart rate's elevated up at 90. It's trying to compensate for that low blood pressure. It's trying to perfuse their body. Respiratory rate's a little high, maybe trying to balance the pH in the blood. BUN and creatinine are just slightly elevated. Normal BUN is 7 to 20, so it's up to 21. And creatinine is usually about 0.6 to 1.1. So that is starting to affect their kidneys. I'd like to know a baseline. Is that where they normally live at? It's not that high, but I know it's elevated. So I'm worried about their renal function. It's something I'm going to watch. Urine output 100 mLs in 8 hours. I told you the rule of thumb is 30 mLs an hour. So if they had normal urine output of 30 mLs an hour, that should be up at 240 for 8 hours. So that is low. How do I assess that? Their urine also starts to get more concentrated, darker yellow, less clear. So things like that also give me an indication, even if they don't have a Foley and I can measure mLs every hour, that they're having problems with their renal function. Medical history, diabetes type 2. So we know they're not insulin dependent, but not eating and having the dehydration could potentially raise their glucose levels. They're not under control. And when you have higher glucose levels, you pull water into the vascular volume and you can have more add to the dehydration. They have heart failure, so we know that they don't perfuse their organs optimally anyway. And they have hypertension, which causes problem to the vessels and can hurt your kidneys long term. So they already have some vulnerabilities, and then you added on this flu, and that's going to be a problem for this patient. So just starting the concept map, we put the information for the patient, the pertinent information in the center. They're elderly, and they've had the flu, they're nauseated, vomiting, and little PO intake. So that right away gives us some nursing diagnosis we can put down and start with. We know that they don't have good urine output, so impaired urinary elimination. It's only 100 mLs per hour. Ineffective tissue perfusion. That blood pressure is too low, right? They're not going to be able to perfuse their tissues and their skin. So we're going to watch for things because of that inadequate tissue perfusion. And really, when you add on the nutrition, that's going to affect their skin too. So we really know that their tissues in their body and their skin are not going to be perfused. They're at risk for, we don't have a glucose level yet, but they're at risk for unstable glucose levels. And they're at risk for electrolyte imbalances. We don't have that information yet either, but we anticipate it. So we can use those risk for nursing diagnosis for things that we're going to watch for and we know that they're potential going to develop problems with. So ineffective tissue perfusion is going to add, like I said, not only organs aren't perfused, but your skin's not perfused. So this patient is at risk for, we don't have a skin assessment. They may have great skin, but we know they're at risk for impaired skin integrity. So I'm going to have to really be overzealous to check their skin, to turn, reposition, make sure they're not having any skin breakdown. They're also, we said, nauseated, right? And until we get that nausea under control, it doesn't say we did. So they're going to be at risk for imbalanced nutrition, less than body requirements. So they're not eating. It's nothing that they're at risk for. We already know that they haven't been eating for a number of days. So they've had less than body requirements. And if the nausea is not stopped, it's just going to get worse. The urinary elimination, impaired urinary elimination is going to put that patient more at risk for those electrolyte imbalances. We're going to have to watch for really, especially the potassium balance because they're elderly. They have heart failure, they have hypertension, they're really at risk for those abnormal heart rhythms that can be lethal for the patient because of the potassium levels. They're going to be at risk for calcium and phosphorus imbalances also, but we really are looking for those electrolytes in this patient. They're elderly and they already have cardiac decompensation. So the one nursing diagnosis of the urinary elimination really puts us to identify the risk for electrolyte imbalance. Because they can't urinate, they're building up fluids, right? Their urine output is 100. We know their BUN and creatinine are up. They're not perfusing their kidneys. They're holding on fluid. They have excess fluid volume. And so we can add that nursing diagnosis, really just building on the information we have and the other diagnosis we have and risk for diagnosis. We can add that excess fluid volume. So what are we going to do? We're going to have a really careful and strict I&O to watch what their fluids in and out. Risk for electrolyte imbalance. I'm going to make sure that the doctors ordered the labs and look and see what their potassium is, importantly. Also look at things like calcium and vitamin D, but most importantly right now I'm worried about that potassium with that patient. Impaired urinary elimination, again strict I&O. Try to get IV fluids started. That'll be in the list of orders that the doctor will give you. So we hope to that will increase pretty quickly. If they haven't gone into renal failure, they should start to urinate more, and I'm going to watch that I&O carefully. I already talked about risk for impaired skin integrity. Those things we want to do a good assessment. We want to turn and reposition, and also when they're not nauseated, really starting to introduce the nutrition again so they have good protein stores that really helps their skin integrity. Ineffective tissue perfusion. So if we can get that blood pressure back up and really stop it progressing into acute kidney failure, then with IV fluids and being able to drink things, we should be able to see that blood pressure go back up and the heart rate neutralize. The nausea, hopefully that'll go away with the flu, but we can give different medications as long as they're not nephrotoxic. Ondansetron, which is Zofran, is often given in the hospital, and that could actually affect the heart rhythm in patients, especially the elderly. So we have to be really careful of what we do to stop nausea. Hopefully this whole viral illness that they have goes away and they are able to start eating slowly, and we get that nutrition back up to par. Risk for unstable glucose. They're not eating. Their glucose levels are and they're probably not taking their medications at home. So some of the orders I would also anticipate with the IV fluids, there probably is going to be some glucose in those IV fluids. Eventually, once they hydrate them, they'll add some glucose, so D5, into those IV fluids, and as they start eating, we should get a more stable glucose. But I want to make sure I have orders that are going to let me monitor their glucose levels with an Accu-Check or whatever you use for point of care testing in your facility. Risk for electrolyte imbalance. Again, I said we're going to watch to make sure we have the orders and also make sure that they're not at risk for electrolyte imbalances causing heart dysregularity. And we're going to have to make sure those levels are normal. We may even put them on bedside EKG monitoring. So interventions, some examples. Make sure we get a weight every day. Remember, 2-pound weight gain means that their really congestive heart failure is getting worse. And when somebody's in renal failure, they're even more prone to having a weight gain, so we want to watch that. Vital signs should be at least every 4 hours. This patient may be in a step-down situation anyway, and you can always do vital signs more often. It's just really a rule for certain levels of care on floors. Usually you can't do them anymore or be required to do them maybe more than every 4 hours on a regular floor. We're going to monitor that I&O every shift, and it's going to be really strict I&O. Monitor their labs. We want to watch specifically the potassium. Skin assessment at least every shift. And then things also you could add, getting the patient up if they can tolerate it and their blood pressure doesn't go down. You can add to this concept map by what you could delegate. So you could, in your interventions, put down, I want to delegate the NA to weigh the patient every morning. I'm going to have them assist me to turn and reposition the patient. They can't assess, but you could delegate them to help you with that. Some expected outcomes you could add to this whole concept map. So you would want to see return of their blood pressure to normal range within 24 hours, within 12 hours. I know with students it's hard to put down the time frame that you expect something to resolve. But if it's something that's really emergent, like blood pressure, and you're starting IV fluids, really the sooner than later. If we're getting IV fluids going and medication started, really that blood pressure within 12 hours, it should be back to a normal range. We can expect the BUN and creatinine to decrease to normal range if they haven't gone in renal failure within 24 to 48 hours. I want that urine output to get back to 30 mLs per hour within 24 hours, and we know that that would mean normal renal function. So those are all, when you look at a care map, you identify the problem, and then your assessments come off of that, and that's what builds your nursing diagnosis. Right? We can put those down and what they're related to. If they're not a risk for diagnosis, if it's a regular nursing diagnosis, it's related to something. So the excessive fluid volume is related to the poor urine output. Impaired urinary elimination related to 100 mLs in 8 hours of urine output. Risk for impaired skin integrity, usually you don't put a related to for that, but we know it stemmed from ineffective tissue perfusion, and that was related to our low blood pressure. So I hope that helps kind of put all the information together when you're looking at a patient with potential acute renal failure and helps you build a map.